So, preoxygenation before anesthetic induction and tracheal intubation was a routine practice that we are all even today taught to do that, which delays the onset of desaturation in these patients. And the difficulties with ventilation and intubation are unpredictable, which is called unanticipated difficult airway. And so the preoxygenation is made a desirable component of reduction of anesthesia in all patients. And during emergence from anesthesia, residual effects of anesthetics and inadequate reversal of neuromuscular blockade can lead to hypoventilation, hypoxemia, and loss of airway frequency. And routine preoxygenation before tracheal extubation also is recommended nowadays. Now there are two things. You must know how effective your preoxygenation is, which is assessed by what is called efficacy and efficiency. Now, what are the indices of efficacy of your preoxygenation? It increases the fraction of alveolar oxygen, it increases the arterial oxygen tension, and decreases the fraction of alveolar nitrogen. So these are the things that we achieve by preoxygenation. The endpoints of maximal preoxygenation, which is an indicator of efficacy, are objective evidences are end-tidal oxygen concentration 90% and end-tidal nitrogen concentration is 5%. Now the efficiency of preoxygenation is reflected in the rate of decline of oxyhemoglobin. That is how soon the patient desaturates during apnea is the hallmark of efficiency. And various maneuvers introduced to extend the prolongation or desaturation or elevation of the head so that the diaphragm is pushed down and the basal portions are well ventilated. Then apneic diffusion oxygenation, CPAP method or PEEP method, and BiPAP or bilevel positive pressure, and THRIVE. All these things have been used to improve the oxygenation. And the benefits of apneic oxygenation include maximal preoxygenation, airway patency is maintained, and high functional respiratory capacity to body weight ratio is achieved. What are the risks of preoxygenation? If you have good, if you have put the tube in the esophagus, because the available oxygen in the lung is still more, for some time you will see the saturation being maintained, which will give a false feeling that your intubation is right. So it will delay the detection of esophageal intubation, and prolonged oxygenation can lead to absorption atelectasis, especially in the basal portions, and it can produce reactive oxygen species, and it can change the hemodynamics, like it can produce a bradycardia and other things. Now, physiological basis, efficacy and efficiency. Body oxygen stores in room air with 100% oxygen body are in the lungs. In room air, we have only 450 ml of oxygen. Whereas in the, if you inhale 100% oxygen, your lung oxygen storage level becomes almost 7 times more than your normal room air breathing. And in the blood, other areas are all very minimal changes that happen, especially combined with myoglobin. There is no change. Dissolved in tissue fluids, there is no change. Blood also has a marginal increase with 100% oxygen, but the amount of oxygen availability in the lung is almost 7 times increased by your preoxygenation. And the terms preoxygenation and denitrogenation have been used synonymously in these patients. What are the stages of preoxygenation are? Initially, what you do is the washout of anesthesia circuit by oxygen flow. So these are entire oxygen and breathing circuits, they are all filled up of room air only before you start giving the oxygen. So first that air has to be washed out. So all the corrugated tubings, the face mask, everything which is filled up with room air, you wash out that and fill them up with oxygen. So it depends on the size of the circuit and oxygen flow rate. And once you wash out the circuit with a high flow, then before placing the mask, you can remove the air from the circuit faster. So you can use the oxygen flush without taking the mask to the patient's face. You can keep it open and then use the oxygen flush. And as you are closing it, you can place it on the patient's face, which will help in denitrating the breathing circuit first. Then you go to the lungs and you wash out the FRC from room air to produce, as I told you, the entire 2500 ml can be replaced with oxygen. So the first step is to remove or denitrogenate the breathing circuit. The second step only you achieve. If you keep the mask and the circuit straight away and then open, the circuit air has to be removed and then only the ventilation will take place. So to avoid delay, especially in emergency cases, you can flush out the circuit of the room air by oxygen flush and then put it on the patient's face to fill up the lung with the 100% oxygen. What causes low FiO2? There are difficult situations like bearded patients, edentalous patients, elderly patients with sunken cheeks, and the use of wrong size face masks, improper use of head straps, presence of gastric tubes are all common factors causing air entrainment and the lower FiO2. So even if you are giving 100% oxygen, if there is a gap between the face and the face mask, it will take a longer time to achieve the replacement of air from the lungs with 100% oxygen. What causes loss of capnography tracing during that? The absence of normal capnography tracing and a lower than expected end-tidal carbon dioxide or oxygen should alert the anesthesiologist the presence of leaks in the anesthetic circuit also. So if your face mask fit is all right, but if the capnograph tracing is not proper, check for any leak in the anesthetic circuit. The factors affecting the efficacy and efficiency of pre-oxygenation are inspired air of oxygen concentration, presence of leak, anesthetic system used, level of fresh gas flow, type of breathing, whether it is tidal volume or deep breathing, and the duration of breathing if you are using only tidal volume breath, and the alveolar ventilation to FRC ratio. All these things determine the efficacy. And the efficiency, oxygen volume in the lungs, alveolar oxygen tension, FRC, and systemic oxygen supply versus demand balance. That is the arterial oxygen content, cardiac output, and whole blood oxygen consumption. All these things determine the efficacy and efficiency. And these are the various methods or techniques of doing pre-oxygenation, which we have been told. And hyperventilation can reduce the time required to increase oxygen stores in the lungs, which provides the basis for using deep breathing as an alternative tidal volume. So when you ask the patient to take a deep inspiration and exhale, you are washing out the carbon dioxide. So uptake of oxygen is much more faster in that situation. And the high risk population who definitely require pre-oxygenation are pregnant patients who have they are achieved more rapidly in pregnant than non-pregnant because of higher alveolar ventilation and lower functional residual capacity. And they tend to develop desaturation more rapidly because of the reduction in FRC, which happens because of the enlarged uterus pushing the diaphragm up or the causing cases. That is all pregnant women are considered to have a low FRC, and the tendency for desaturation is much more there. The gravid uterus prevents the descent of the diaphragm. And 4 deep breathing technique is inferior to 3-minute tidal volume breath technique and should not be used except in emergencies. So in cases where you don't have time to do the 3-minute normal tidal breathing technique, you can employ 4 deep breathing. But if time is available, always the safe method is to use the 3-minute idle volume. And increased minute ventilation in pregnant women requires oxygen flow at least of 10 liters per minute used during preoxygenation. So you must open the flow meter to 10 liters before you place the mask on the patient's face to deoxygenate. And the second category is morbidly obese patients who also have a low FRC. That is the reason why they can also desaturate much more faster. And their time is only 2.7 minutes compared to the 6 minutes when they have saturation of 90%. And if they are complicated with obstructive sleep apnea, more so you have to make sure that you are able to mask ventilate them correctly before you do the intubation. And they have more increased oxygen consumption and reduced functional residual capacity, both make them susceptible to desaturation much more faster. And a 25% head-up position or a ramp position during pre-oxygenation helps in these patients. The third category is pediatric patients. Younger the child, faster the onset of desaturation. So, and the chances of bradycardia and arrest. So, in infants, saturation of 90% is reached in 30 to 90 seconds after the onset of apnea in spite of pre-oxygenation. And this period is shorter if there is a pre-existing respiratory tract infection. Similarly, very elderly patients, lung volumes are decreased and increased closing volume or closing capacity resulting in ventilation perfusion mismatch, which is the reason for reduced pulmonary reserve and impaired oxygen uptake at the lung. So basal oxygen consumption decreases with aging, but the impaired oxygen uptake compensates for that. So they don't have enough ability to take up the oxygen, even though they don't require that much oxygen. But the inability to take up the oxygen makes them susceptible for rapid desaturation. Okay, and patients with pulmonary diseases already decreased functional residual capacity, and they have appreciable V2 mismatch, and they have increased oxygen consumption. All these factors, three factors, put them at the risk of desaturation. They reduced FRC, impaired VQ mismatch, and increased oxygen consumption are the problems in patients with pulmonary disease. And atelectasis is not a consequence, but because of chronic hyperinflation, the lung resists their decrease and collapse in these patients. And patients at a high altitude, when you anesthetize patients at more than sea level situations, patients at high altitude will require a longer duration of reoxygenation to achieve the same amount of saturation that we do in the sea level patient. And the potential risks are delayed diagnosis of esophageal intubation already told. So normal pulse oximetry reading after intubation should not be regarded as an evidence of proper endotracheal inhalation placement. And there is a severe fall in SpO2 relatively late manifestation of esophageal intubation if you have given a very good pre-oxygenation. And absorption atelectasis, this is a fairly common problem. One mechanism is decreasing FRC. Second mechanism is compression atelectasis. Increase in intra-abdominal pressure leading to compression of thoracic cavity and airway closure. The third is production of reactive oxygen species. Of course, this is a very late and not a very common pair. This happens because of too much of oxygen not being utilized, and this oxygen with the two unpaired electrons in the outer shell is a highly reactive oxygen element, so that will cause all the problems. And the dioxygen molecule can accidentally or deliberately split, producing reactive oxygen species. So the commonest examples of reactive oxygen species are superoxide ion, hydroxyl radical, and nitrogen peroxide. And they can cause cellular damage by interacting with the lipids of the cell membrane. And clinically, that may manifest as pulmonary edema. So one examiner was warned of asking, if you give 100% oxygen, is there a possibility of producing pulmonary edema? The answer for that is this. Yes, and if you give 100% oxygen for a longer time, can produce all these reactive oxygen species, which will damage the alveolar membrane and produce pulmonary edema. So oxygen, which is a treatment for pulmonary edema, can also be the cause of pulmonary edema in a very rare condition where this complication has happened. And acute respiratory distress syndrome, retinopathy of prematurity, all these seizures. Excessive, of course, oxygen toxicity can manifest as lung toxicity and central nervous system toxicity. So that is a topic by itself. So prolonged oxygen or too high concentration can produce this problem. And because of the short duration of exposing the patient to 100% oxygen, this injury to that will not be always applicable to pre-oxygenation. Whereas in ICU setup, if you give oxygen 100% oxygen for a longer duration, then there is a possibility of these things happening. Then cardiovascular responses are modest decrease in heart rate and decrease in cardiac output with 100% oxygen inhalation. And there is a systemic vascular and arterial blood pressure, they both increase. And hyperoxia constantly causes decrease in coronary blood flow because reflecting coronary vasoconstriction accompanied by decrease in myocardial oxygen consumption. So this is a very paradoxical situation. So any excessive oxygen is going to affect the coronary blood flow. And the inactivation of nitric oxide and other vasodilators released from the vascular endothelium causes closure of ATP sensitive potassium channels. And inhalation of oxygen also reduces cerebral blood flow because of vasoconstriction. And PaO2 is increased by inhalation of 100% oxygen. CO2 dissociation curve for the blood is altered. It is called the Christiansen-Douglas-Haldane effect, such that there is a reduction in the affinity of blood for carbon dioxide. So these are all the points that we have to write for pre-oxygenation.